Thank you for joining me today. I have a story here for you that is provider perspective. So the patient blood pressure is still elevated. You have seen them multiple times now. They have been taking their medication. The medication barrel confirms that. Their story matches the refill story. 3 agents are already on the board, including diuretic, each at the appropriate dose. Lifestyle changes were discussed months ago. Revise the last visit, particularly implemented. Yet today the reading is unchanged. Before taking any adjustment, you pause, not at the medication list, but at the measurement itself. The cuff size is correct. The patient rests. Feel flat back. Feet flat back supported. Arms at the heart level. You repeat the reading, slightly lower, but still above the goal. So the blood pressure is still above the goal. Now the border decision begins. Now the decision begins. Now the broader decision begins. You consider the physiology. Is this a primary drive by the cardiac output, peripheral resistance, or both? Could there be underlying secondary cause that has not yet been recovered? Resistant hypertension is no longer a definition in a tax. It is appropriate for deeper evaluation. Renal diseases, endocrine causes, medication interaction, lifestyle factors all move higher on your differentiation diagnosis. You revisit non-pharmacology strategy, knowing that the lifestyle changes can reveal the effect of adding other drug, sodium intake, weight, physical activity, alcohol use. These conventional are not always easy, but they are necessary. At same time, you know this patient is comorbidity place. Is comorbidity place. You know this patient's comorbidities place them at higher cardiovascular risk, making timely blood pressure control essential. When you do a chest therapy, the choice is deliberate. Evidence guides you, but the decision is individual, accounting for comorbidity conditions, concurrent medications, cost, and what this patient can realistically sustain. The medication itself matters, but what matters is whether the plan actually helps the patient reach goals of a blood pressure safely. As the visit ends, you schedule follow-up sooner than usual. Not because the protocol alone, but because this patient is risk complexity. Because of this patient risky and complexity and current control demand closer monitoring. Hypertension management once again provides to be less about treatment numbers and more about managing long-term risks. Thinking about the patient with hypertension, those blood pressure remains above the goal desired therapy. How did measurement technique and lifestyle factors, comorbidity, or possible secondary causes influence your next step? How may apply these key concepts earlier change your management approach in the future cases? Choosing the right medication. The diagnosis is not the challenges. The blood pressure has been elevated on 3 separate visits. What takes more time is the decision how to treat the blood pressure. You review the chart before walking into the room. The patient is a newly diagnosed but really high risk. Okay.